just excited to be here. Thank you all for showing up at in the evening for having an interactive session. I look forward to this
Cool.
interaction.
So we typically start with you just explaining what your specialty is and what cases you typically deal with, and then also the path to getting there. So med school, what residency you do, and fellowship.
So I'm a pediatric gastroenterologist by trade. I trained in India. I've trained in New York. I've trained in Nepal. I have worked in Florida. I have worked in New York, and now I'm currently in St. Louis, Missouri. The path to this was so typically in Indian households, you decide that whether you want to do medicine or not in your high school. So by 10th grade, I had to decide, or I had to commit that I wanted to do medicine, which means you need to do science and you need to take biology in 11th grade and 12th grade. And then from there on, you get into competitive exams, so something very similar to MCATs. And then based on that, you get matched to a medical program of your choice. I ended up at Manipal College of Medical Sciences in Pokhara, Nepal, where I did 4.5 years of medical school training. Then I came back to India for a year of clinical internship. So, at least in India, it's based on the Canadian system or the UK system, where you do 4.5 years of classroom teaching along with some practical education. And then you do 1 full year of clinical internship. And that's part of your medicine program, which is Bachelor of Medicine, Bachelor of Science, and that's MBBS. After that, I decided I wanted to come to the United States. So I decided to prep for USMLEs. While I was doing my internship, I gave my USMLE exams. I came to the United States. I spent about a year and a half, I guess, prepping for USMLEs, but then I also did a lot of research at that time. And that was I was in Connecticut Children's Medical Center and I did some observerships. After that, I matched into residency in New York at Nassau University Medical Center. It was a great community program. It was a decent sized program back then. Now it's a little smaller. And then I did went on to do a chief resident here, which was a 4th year admin role, where we were also partially attending in the evenings. So it gave me a good transition into real life. But I was very clear I wanted to go back to India to practice. So I actually went back to India and I practiced as a junior attending, or in India, you still have to do 3 years of postgraduate junior attending training, or not training, work. So we did that for 2 years. And my heart was always in GI. So I really wanted to do pediatric gastroenterology. And in India, subspecialty. So that's what's considered. So pediatrics used to be considered a subspecialty of medicine. And then in order to have a subspecialty, you want to do peds GI. There's literally two positions in the whole country. And I wanted to be very clear that I wanted great training for peds GI. So then I applied to the US fellowships and I matched at University of Florida in Gainesville. So packed our bags, moved across the world again with my family, and then did my 3 years of fellowship training. And then I worked as an attending in Miami for a good 2.5 years. And then because of our family situations and my wife works now at WashU, we moved to St. Louis. In that time, I realized I wanted to do not just treating patients with their medicines, and I kind of felt that there was a mismatch between how I grew up and how I was seeing a lot of chronic diseases in the United States. So I went ahead and did a training in pediatric integrative medicine, which essentially combines a lot of modern medicine along with conventional wisdom passed on from ages, driven with scientific data. So it looks into Chinese herbs, it looks to Indian herbs, it looks at relationships, social impact, psychological impact, how movement affects, how exercise affects all disease courses. And I did 1 year of fellowship on that, which led to me being the medical director and the founding person for a program called Imagine, which is integrative medicine addressing GI needs with evidence. And then we started that about 2 years ago. So that was me ranting 90 seconds about my professional medical journey.
So there is a lot to talk about. So we'll kind of try to cover as much as we can. I'm curious, were you always interested in GI, and how did you kind of find your interest in GI?
I think I was always interested in GI. To be honest, I was never interested in being a physician growing up because both my parents are physicians. And I think as a child, I hated the fact that my parents' time belonged to somebody else. And it's so flipped now because we would go on vacations and they would find their patients, and it would just like as a child, it just really upset me that my parents' time was still being given to somebody else. So up till 10th grade, I was like anything but medicine, but I think I had a natural inkling towards that. I really wanted to be in a field where I could interact with people because being with people is something which I really enjoy. And I was really good at biology. So I think it was a natural course to do medicine. Honestly, midway into med school, I still wanted to think that, you know what, I'll just get over this, do MBA, get a pharmaceutical company, get a 9 to 5 job. This is not for me. And then pediatrics happened. So my first clinical rotation was pediatrics, and I had an amazing mentor. And I just had such a great time just learning about kids and seeing them smile and interacting with them. But just seeing the resilience of children is what made me become a pediatrician. Growing up, I always had GI issues. So again, you understand and you're more empathetic towards something which you've gone through to generate an interest. So I was always more curious. To me, it was more of what I was good at naturally drove what I wanted to do. And hence, once I did peds, I actually wanted to just be a pediatrician. And then I realized that the need of the hour was I wanted to do peds GI. And that's how I did peds GI.
So you mentioned having a really good mentor, and PhysiLink kind of focuses on helping students find a mentor. I'm curious what role the mentor played or in your life in deciding pediatrics, and maybe some advice on how students can find a mentor like that.
Mentors come in all various shapes and sizes. You just have to keep your eyes open, right? This mentor of mine, he was a young faculty at my med school, and he, I think, just had finished his residency. And when they were asked to teach us, he was just so skillful at his craft. His intelligence was almost magnetic, and you could see he embodied passion for the field. So I think I just got charmed into that intellectual aspect of this mentor of mine, and I naturally gravitated towards him. I sought questions and I would read up just to be able to impress him, as funny as that sounds, and that led to more interactions, which then led to me wanting to know more and more, and then he would give me harder assignments, and then we would have these side conversations about how life of a pediatrics person looks like. I think that was my initial memory of being that mentor. And once I came back home, same thing. I is in India when I chose a harder, I guess. So we had to in clinical internship, we had to choose which units we were part of, which means which teams we were part of. And I naturally became part of this team which dealt with thalassemia kids. And those kids are probably the most resilient ones. I'm nowhere close to a hematologist oncologist, but just being in the vicinity of that, understanding that just naturally grew my curiosity. And then essentially I just started speaking to all these people who had done peds, and then my own pediatrician, who I knew since I was probably less than 1 year old. I would just talk to him, and then I started going to his clinic while I was still doing internship, just to hang out. It had nothing to do with putting it on my resume. It was purely I just wanted to hang out and see how those interactions worked. So I think for me, a lot of those mentorships are very subtle.
So I guess your advice was just like you shouldn't intentionally look for a mentor. It kind of just happens naturally as long as you're.
So I think when you want to look for mentors, I also feel like people get really siloed into this is what I want to do, and hence this is the mentor I want to see. Like mentors can be from a completely different field of life, yet be able to guide you through where you want to go. Because a good mentor is a person who makes you realize your capability. May not necessarily. I've actually been mentors to people who did not end up doing PhD, and they're still in touch with me. Or there are other couple of mentors who are adult gastroenterologists who have ended up meeting and talking, and I did not do the path because somebody invented the wheel, and you want to learn their process and you want to learn their passion and how can you drive from there. So if you intentionally seek somebody who brings out clarity in your thought, should be your mentor, is my opinion on it.
Yeah, that makes perfect sense. And then we also talked a little bit about integrative medicine at the beginning.
Mhm.
I think it's a relatively new term, and I want to say it's like this. the like certifications or education is relatively new, even though it's based on, for lack of better words, older practices. So do you mind talking a little bit about what it is, why it's worth pursuing, and I guess like why you pursued it?
I want to look at all of you guys and think of your earliest memory of childhood, right? And then think of what your parents used to be told by their parents on common ailments, how to live life, and how to be healthy, right? So 20 years ago, you did not have information at your fingertips. There was no AI. Honestly, there was no internet either. You relied on information given to your parents by their parents and their grandparents. And that information came from mostly real world experience, not double blinded, randomized controlled trials. And it came culturally, which means if you were in Latin America, it was very cultural driven. If it was India, it was culturally driven. If it was China, it was what Chinese practices did. And most of them relied on ancient techniques of healing because back in the day, you needed healers. And those healers talked about empowering living, not trying to fix disease. And somewhere, when modern medicine took over, we started getting fixated on disease and we forgot healthy living. Most disease is not a new entity. I think it's lack of healthy practices. For me, we in Miami, we were going through a lot of changes. COVID had just happened, and everybody was kind of in this weird situation where we didn't know if medicine worked at all. So when I was seeing patients, I realized that I was giving them advice which my grandma used to give to me, which means don't eat after sunset, make sure you're working out, do not immediately exercise after eating, make sure you're up before sunrise, things like that. Just and then I started telling this to patients just because at that time you wanted to give them some sort of an advice. But in order to be able to stand my ground, I started researching on that and then started to figure out that there is linked to your rhythms, your routines, movement, what you eat, what you don't eat. And that has a direct correlation with the incidence of chronic diseases rising. Computer had come in, internet had come in obviously by COVID. AI was just starting, which means algorithms was a thing. And once I started putting all these research search words, buzzwords on, then I came across the Andrew Weil Integrative Center. And then I realized this was something which adults used to do. Very limited data on peds. And that's when I started researching on pediatric data. I was really interested in not giving medicines because somewhere in my head, I realized that a lot of my issues growing up as GI issues, my dad would just give me fennel seeds, and he's like an adult gastroenterologist. Or during my med school finals, I had such severe anxiety at night, and it was anxiety from being really well prepared that I would not be able to sleep, which would lead me to have like a lot of belly pain. And I remember him coaching me on the phone with a technique called the Yog Nidra. And that's how I would fall myself to sleep. So it was me going back into that wisdom, which then I started seeking out who else has done it. So that's how I brought about integrative medicine. And then I met my other mentors from there on.
Do you mind enlightening us with your technique that you use for anxiety and falling asleep?
So it's called the Yog Nidra, which now, if all of you are pretty tech savvy, which means if you have ever followed Andrew Huberman, who made this a big deal of what is called as NSDR, which is non-sleep deep rest. So that's the Americanized version of this. Yog Nidra is something which yogis have done and sages have done since centuries, which is to put yourself in a very heightened state of awareness, but extreme deep rest. And that is almost counterintuitive because you're not in a state of sleep, but you are so present in that moment that you have drowned out all the noise around you. And eventually, anxiety is excessive negative noise in your own head, right? Nobody's ever anxious about happy things in life, right? Oh my God, I'm going to get the greatest gift. You're not anxious. Or, oh my God, I'm going to get the greatest grades on this test, right? You're anxious about what if I fail? What if I die? What if this happens? So if you drown out the noise, that even negative noise gets drowned out, your body comes to a natural state of rest, even though it's heightened. And 15 minutes of yoga nidra actually is equivalent to almost 5 hours of sleep in terms of recovery. But I hadn't reached that heightened or level of sainthood yet. So I would just, when my dad would talk me through this process where you're essentially doing a body scan, you're trying to do a very hyper focused feeling of what your each muscle is feeling, you eventually fall asleep.
Cool. I will definitely look it up and try it out because I think it sounds super unique and it sounds very helpful as well. Kind of going back to pediatric GI and to everybody listening as well, if you have any questions or want to ask anything, feel free to use the chat and Q&A feature. But I'm curious if you want to talk a little bit about the cases you typically deal with in pediatric GI. And then with pediatrics in general, there's like additional challenges, good challenges and like just challenges that might make your role a little bit harder. So maybe just talking about that as well.
So in pediatric GI, we see kids ranging from the age of 0 all the way to 18 years. Some institutions will take 21 years, and 0 is also not a fine 0 because in the neonatal ICU, a lot of kids are technically born before they've reached term gestation. So preterm babies all the way to 18 years of age is at least what I see. The common diseases we see is, think of GI tract as literally the largest organ system of the human body, which means it actually starts right at the mouth and goes all the way to your bottom. So any problems relating to, from your process of ingesting food from your mouth to your food pipe to your stomach to your small intestine to pancreas to liver to your large intestine and pooping problems, that's what I see. Some of the common reasons why anybody sees a pediatric gastroenterologist, so 25% of my population is constipation, lack of shit, or lack of poop for a better word. But a lot of belly pains, a lot of nausea, vomiting, diarrhea is what we see. Some of the common terms that you guys would have heard would be celiac disease, irritable bowel syndrome, reflux, um, pancreatitis, and then inflammatory bowel disease is what we see. We also are the only branch of medicine which formally sees nutritional cases from a medical case point. So there are lots of kids who can't eat and they need nutritional interventions, whether it is through an injectable nutrition or whether it is putting surgical tubes in their bellies to feed them. So we end up seeing a lot of those issues as well. I think being a pediatrician is actually a lot of fun. It got its challenges because your patient's not just the patient. Your patient is also 3 people who come with the patient, which is usually the mother, the father, and either the grandparent, right? I spend more time talking to them and counseling them than honestly alleviating children's ailments. The good part is 9 out of 10 times children are very, very perceptive, which means if they're feeling great, they'll let you know. If they're not feeling great, they'll let you know. There are no layers to kids. When they feel better, they're amazing, they're up and about, and when they're really feeling crummy, you can see it on their faces. What's hard is majority of my population does not know how to speak, right? So it's figuring out what is causing them to not feel so great. But there are also kids who give you drawings. I don't think a single adult patient will ever make you hearts and write I love yous on cards and give them to you. So every day is a lot of fun. And I think it's extremely rewarding because children, they get better really quickly.
And so you mentioned a little bit about nutrition. Is that something that's kind of part of GI training or you do that separately?
As part of your fellowship training, or in an ideal world, you're supposed to get more hours of training. But yes, the biggest body is called as North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. So it's NASPGHAN. That's our biggest sort of world body, and every country has their version of this. But nutrition is part of our training. Nutrition is something which we see. So about 10% of my population is pure nutrition counseling and education, and figuring out what their caloric needs are, figuring out what kinds of intervention we need to do.
And does your role involve any procedures at all, the GI tubes and that kind of thing?
Right. So our roles involve doing an endoscopy mostly. So endoscopy is putting a camera through your mouth, into your food pipe, into your stomach, into your small intestine. We take little selfies, we take ourselves out of it, We take tiny little biopsies, which is tissue samples, and that is seen under the microscope. That's done by the pathologist. We do the same thing from the bottom up, from your butthole to the colon, all the way to the alimentary tract. So those are the two common procedures which we do. Certain advanced endoscopists also tend to do things which have got something to do with the pancreas. We also do what is called as liver biopsies. It means there's a little gun, it's got a needle in it, and we go from the outside into the liver to take a little piece. And a lot of institutions, including mine, we end up doing these tubes for nutrition ourselves. It can be done endoscopically. See, we're not surgeons. Let's get really real about this. We're not surgeons. We're not as bold as they are, and we're not as badass as they are. We're gentle badasses. So we do it minimally invasive. We do a lot of camera work and a lot of interventions where we just look. So those are the procedures which we end up doing.
Cool. So our pediatric GI, do y'all typically do inpatient in a hospital, or are there ever outpatient opportunities as well?
So it's the right mix of both. Most pediatric GI, 75% of our work is actually outpatient, 25% is inpatient. So in a setting like mine, currently I'm in an academic institution and we are 8 of us. So we take call once every 8 weeks. But previously, when I was in Miami, we were a group of 4 people. So we would take call once every 4 weeks, which means you were inpatient for a week and you were outpatient for 3 weeks.
Got it. Wanted to talk a little bit about your day-to-day schedule, and then you mentioned this was an academic institution, so how that kind of changes your weekly schedule as well.
So it really depends on how you want to see your academic career as, or how do you want to see your professional career as. And I've had the fortune of working in a private setup, and then I came to academics because I just have the love to teach. A gastroenterologist in the private world will essentially start their day in the mornings. In private world, you tend to decide your own timings. Miami is more laid back, so the day started at about 9, it ended at 5. Most other places, so Northeast, your day will typically start around 7:30, and end by about 4:30. In an academic institution like mine, so Monday to Friday, I work 5 days a week, out of which all our days are broken into 2 sessions. So each day has a morning session or an afternoon session. I have 1 admin session and 1 academic session. So technically, I'm patient facing for 8 sessions in a week. My day starts at about 8:30, and I'm usually home by 4:30 or 5 at the best on my days of outpatient. When I'm inpatient, it ranges. If there's an emergency procedure, different story. But again, my inpatient ranges from about 8 to 3 to 8 to 4. So amazing work-life balance in an academic setup. So out of these 8 sessions, 2 of sessions are going to be procedural based, which most gastroenterologists really like. All of us are more inclined to do procedures because it's like playing a video game. And if you like that, it's kind of fun, and then you're in your zone. So almost 9 out of 10 pediatric gastroenterologists do gastroenterology because it's an easy way to get into the procedure wall. So you can still have your continuity. It's not like an ICU. It's not like an anesthesiologist. It's not like ER, which is very procedure heavy. This is where you do your couple of procedures. So you do about 6, 7, 8 procedures a day, and you call it a day. Because in an academic role, you also have teaching responsibilities. So we have certain time frame, which is kind of built into our schedule. This whole 8 sessions is built around the schedule that we are expected to teach residents, fellows, and medical students. Wednesdays is technically, for me, is my academic day. So again, we are taking part in the education of training the next set of physicians, and that's our typical half day. In the private role, on the other hand, I would see just patients morning until evening till the time it was my procedure week, and then I just did procedures day in, day out.
Cool. Okay, so we always talk about work-life balance with every webinar that we do, and it appears you have a pretty good work-life balance. I'm curious, like, do you ever take work home? And also, what do you enjoy doing for fun and kind of just make sure that you're not stressing yourself out and getting burnt out?
So if this webinar goes out to the people in my generation or the older millennials, they will hate this term because we grew up in an environment where there was no work-life balance. So for me, doing where I am today is a very conscious decision of the work-life balance. My very conscious decision is that once I leave office, I don't bring work home. So This webinar itself is also a little outside what I normally do, right? Which means and I used to do this a lot 5 years ago. I would take meetings, I will answer patient messages, patient calls, things like that. But I chose a specialty which there is emergencies, but those emergencies can be handled by the physician on call. So there's a reason we take calls. Um, and hence that was a very personal choice. I still have colleagues who will take work home. I just don't, which meant that I had to become really efficient at my work. So my goal in life was I'm at work from 8 to 5, make me work as much from 8 to 5. But after 5, my time is mine and I will not look at a patient chart. It took a lot of time to get there because you have to become really confident in your craft and not keep worrying about what if I did something wrong? What if that medication did not work? And as physicians, you end up taking a lot of that mental load home. And I started realizing that when I take mental load home, I am not fully present with my family, which also deserves, and I think goes back to my childhood. I think I missed out on that from my parents because they were constantly seeing patients. Um, so how I did that was this is my second like big boy job, which I was very clear about negotiating that how many on calls am I expected. So even in this phase when I'm not on call, we take every alternate week, I take a night call. So which is I'm available by phone from 5 p.m. onwards till 7 a.m. next morning. And I'm available by phone. So that's one day where my family knows I know that I'm going to be sort of not available. My previous job in Miami was a private place, and I think I actually ended up leaving that place because of the lack of work-life balance, because I was on call a lot, and I think that just took a toll on my body as well. So uh, it's also a specialty. For example, my wife is a PZR person, and she thinks she has a work-life balance, and I think she'll agree with that. But because of shift work, I'm not a person designed for that. I cannot do shift work, which means I want to be able to sleep at 10 p.m. and I want to be able to wake up at 5 in the morning. I'm not a person who you should expect to work at night. So I think it comes more from clarity of what you want your work life balance to look like.
Yeah, I think it's cool how you were very intentional about it and kind of planned it out per se. But I guess you're right where it does take a lot of time to set it up where it's how you want it.
Because if it's my first job and the first thing I asked my boss, like, so what do you guys do for work life? That kind of, at least remember, a lot of bosses are still from a generation older than mine. That just comes across as, wait, why are we talking about work life first and not work first? So
Right.
I think a big challenge is navigating that space. And we are hoping that we're getting there. And people in my generation and the generation after actually changing that dynamic also. But the reality is, a lot of us are in this profession for pure passion of it. And I recommend that to everybody. If you don't have passion for service, if you don't have passion for helping people out, you're going to burn out pretty quickly because it takes a pretty huge toll. And then there are certain fields which is just not conducive if you want to spend a lot of time home. So, for example, if you want to be a great transplant surgeon, which we will deal with if we have a liver transplant coming in, they have to come in the middle of the night whenever the transplant's happening. So if that's something which is non-negotiable for you, then that's not a field for you.
Absolutely. Um, so the gastroenterology field is, I want to say there's a lot of recent developments and the gut microbiome is kind of like a buzzword in research. I'm curious if you've seen any changes or developments over the past couple years in either research or technologies that you've used.
So both research and technology is advancing faster than we can fathom. The gut microbiome space is now being essentially linked to everything which happens in the human body, right? But if you look back at really older teachings, they just called it memory. If you look at old sages and sermons teaching, they will say human body remembers and it's the memory. And that's exactly what genomic imprint is. And the genomic imprint is linked to your gut microbiome. So human body currently hosts 100 trillion organisms other than the human body itself, right? Other than your human organism, you have 100 trillion microorganisms. I think our research is just scratching the surface of what this entails. How do these other trillion organisms interact with human body to promote health or to promote disease? And I think we are still figuring out which the imbalance is. I end up seeing a lot of patients and parents curious about the gut microbiome and its effect on the human body. And I think there is a huge effect. I just don't know, we know linearity and how causal each relationship is. Um, some of the tools, most tools in pediatric world come down as a trickle effect from adult world. So you have to remember the biggest challenges being in pediatrics and in research is that when you consent for research purposes, you have to consent the parents and the child. And therefore, ethically, it becomes a lot harder to conduct pediatric research. So you have to rely on adult data. And what history has taught us and what all teachings have taught us is children are not mini adults. So you cannot, if, say, for example, at your age, if you're lifting weights and you're taking a creatine supplement to jack yourself up, that will not hold true for a kid because that will ruin that kid's kidneys. Right. So it's not that there's many adults and you just half the dose and you figure this out. So I think research will always lag behind in pediatrics. And what we are now trying to find out, we used to try and mimic mouse models and pig models because we thought that their intestines and their gut microbiome behaved a similar fashion in human behaviors, and we realize that it doesn't really correlate. It gives us a little sense that this may happen, and we still have to do work with real world data, especially when it comes to microbiome. There's a very nice Netflix series. It's called Hack Your Health. And if anybody hasn't seen it, please watch it. It talks a lot about microbiome and how it can even affect your mood to your health benefits. And then my favorite line for everybody is, as humans have evolved, right? So humans evolved till the time we were trying to adapt to environment. Once we started controlling the environment, we forgot to evolve, right? So if your grandmother told, if you look back at 20, 30 years ago, the food we ate 30 years ago and the food we ate today is so different, right? Food today is so artificially lab grown, and food 20 years ago was most plant forward, most fiber rich. I remember drinking water out of hoses in India where you were getting exposed to all these microbiomes and that was shaping our immunity. I think now we are creating things in sterile environment, which is then creating a little disordered microbiome, so to say, and we're still figuring that out.
Any advice for us at this point? Like you're right, a lot of food is processed, grown in or created in sterile environments. How should we I guess kind of reverse that effect or help ourselves better?
Okay. So is the group here mostly what, high school and middle school? Is that what the group is?
No, I would say most of us are undergraduate students pursuing the pre-health track.
Perfect. So
Probably pre-med, to be honest.
which means most of you are not living at home, or are you guys living at home?
Living away from home, probably in
Yeah,
college.
I see a lot of shaking of heads. Okay. So then I'll give you a practical advice. Practical advice is, if you can control your taste buds a little bit and you can control grabbing the first glitzy thing, which is to eat, you'll be fine. So I'll explain that in a second. So my rule of thumb is, whenever you open anything which comes out of a bag, flip the bag. If it is less than 5 ingredients, it's possibly safe. It'll be fine. Okay. Number two is, if you, as pre-health frac, cannot pronounce an ingredient, please don't put it in your mouth. Whenever possible, eat things which don't come out of bags. So whether it is grains, legumes, poultry, chicken, meat, fruits, vegetables, right? And fifth point would be very careful of deceptive marketing. Eating healthy in America is expensive, and I fully understand that. So 80% control your mouth and you'll be fine. Try as much possible as to eat lots of fiber, which means make fruits your friends. I know vegetables are hard, but pick a vegetable and see if you can eat it all day long, and you'll be great. And just prioritize more whole foods than processed foods, and your gut microbiome will be fine.
Thank you for that. As someone who hates fruits and vegetables, I should definitely try to clean up my diet. We have a question in the chat, and so if anyone else has any other questions, feel free to ask them now. In probably 5 minutes, we're going to switch over to a couple case studies. We'll probably run to around 8:10 in Eastern time. So let's see. The question is, in terms of research and progression of PEDS GI, how do you see AI playing a role in the practice and better understanding the child physiology versus adults?
I think people and physicians who don't evolve along with AI will get left behind. I think AI is going to start leveraging a lot of tools to explain things a lot easier. I leverage it all the time, especially for research. Having said that, I think there's a downfall to AI, which means right now it's still a language model. It's not a reasoning model, which means it literally just recognizes patterns. It may not do as well of a reasoning as what we think it does. It recognizes patterns and then it sort of regurgitates that, which means any Tom, Dick, or Harry can put anything on the PEDS GI world and that'll get picked up as dictum. AI tools will help researchers put out the material a lot faster. So when I do a study, all of us have lots of clinical ideas, but when I do a study, the problem comes in compiling data. The problem comes in what's my background research about? Can I summarize these papers? And I think AI is going to help that. So you will end up seeing a lot more papers getting published, smaller studies getting published. So I think AI will really help with that. And then the second part of that was and better understanding the child physiology versus adults. Again, so it'll help us recognize patterns in children. So back in the day, as PEDS researchers, we just shied away from doing research because it was never a randomized, blind, double-blind controlled trial because it's just so hard to do. So most of our adult folks will just, sort of piffy our work saying, well, you don't have outcomes-based data. So then we started doing real-world data, which now AI helps with. So for example, you have all these insurance claims data, which has a whole bunch of codes, which as a layperson is very hard to decipher. So I think with AI, we'll be able to decipher the codes. So this is not doing consent. This is all de-identified data, but we can understand patterns in peds, and we do the same in adults, and that'll help. And interestingly, that was my thesis project for fellowship, which ended up getting published, which we compared pediatric inflammatory bowel disease to adult inflammatory bowel disease using this large claims data. So we ended up looking at 21,000 people, out of which about 10,000 were kids, about 11,000 were adults. And we did a pretty direct comparison that the same disease presents differently in kids versus adults. And that's just not because the disease is different, but it's because how they seek healthcare access, right? So adolescents who are away from home, right? They're not going to go back to their peds gastroenterologist. They're going to go to the ER, and those medical charts don't cross over. So they get treated with different medications, and that affects their physiology. So I think we'll be able to leverage AI more and more, and hopefully we understand children physiology a lot better than adult physiology.
Cool. Okay. I also think it's cool or interesting how you mentioned pediatric research is always going to lag behind adult research just because there's a lot more challenges and layers that you have to go past.
Which is a lot of people don't understand, right? So a lot of people get into, and the caveat to that is, which most people are very scared to ask, like money, right? There's a lot of money riding, and PEDS doesn't make money. The reason PEDS doesn't make money is because the research is so hard to do. When research is hard to do, pharmaceutical companies cannot make drugs specifically for children. When they cannot make specific drugs specifically for children, they don't make profit. When they don't make profit, they don't fund research, and it's a vicious loop, right? And most pediatricians are trying to prevent disease. Most adults are trying to cure disease. And prevention will never make money in the healthcare sector. It will make money in the longer run, which unfortunately our policymakers don't understand. But PEDS research doesn't pay as well, and neither do get pediatricians compared to the adult counterparts.
Yes, preventive medicine and reactive medicine is something that we talk about a lot in undergrad. All right, so there's two really brief questions that we typically ask for ending the interview portion of this. And the first question is, do you have any advice for students in general as pre-med students in either high school or undergrad?
Advice in general or going into healthcare?
You could relate it to healthcare, whether that's like exploring different medical careers, balancing, burnout, anything.
I think it's very important to really understand where your mind and head is at. Be I don't tell medical students, undergrad or health pre-med track people to commit to a field. There's a lot about human body which can be very fascinating. So talk to people. You don't necessarily have to go hospital rounds, but other than that, also be extremely open. I feel like this is the age where you want to be open to ideas, open to things that you want to do. Don't commit to yourself to this is the location I want to be, this is the place I want to be. Life is extremely dynamic, and I think you should get as many experiences as possible. Number two, healthcare, what I've learned from me is because I've practiced in so many different places and because I've lived in different places, it actually helps me open up a lot of empathetic ear to patients because I can understand where they're coming from, whether it is a New Yorker or whether it is somebody, a Latin American, whether it's an Indian, whether it's Pakistani, whether it's a Chinese, whether it's a Nepalese. The more you expose yourself to people, the better you'll have empathy. And I think that's what's missing in medicine these days. And unfortunately, we don't teach anybody that. We don't teach physicians listening skills. Listening skills will happen when you start communicating with a whole diversity of people. When the only thing I tell med students, residents, and fellows in training would be avoid staying in the same place as long as possible because then medicine is it travels, which means you will have immigrants, you will have people from different states, people from different cultures, and you cannot play a blind eye because you cannot treat them if you don't understand where they're coming from. So I think this is use your time to just interact with as many people as you can, and it'll show up in some form in your career.
I think that's great advice. Thank you. And then finally, if you had to convince all of us to pursue pediatric GI, what would you tell us?
What's not to love? You get to talk about poop emojis. You get to say the word shit. You get to color your poop emojis in unicorns, and every single child in the history of mankind has had some tummy ache issue at some point. Look back at your own lives. If you can make even the slightest of difference, I think it's the most gratifying, satisfying feel. Also, it actually pays reasonably okay.
All right, perfect. Thank you so much. If you want to maybe present your slides, I think that'll probably be the easiest way to do it. And then we'll do this for about 15, 20 minutes, and you could take your time too. There's no rush.
I didn't go over a lot of things. It's quick. I just wanted to give you guys an update of what I'm doing and what I think the world is headed. And I really think that harmonizing holistic and conventional approaches will be the new paradigm for pediatric GI care, right? So at some point, you guys will all learn what Hippocrates said, right? So Hippocrates said that before you heal someone, ask him if he's really willing to give up the things that make him sick. So, Sham, to your question earlier, that what advice do I have for you guys improve your gut microbiome or gut health is look at your state as a health state and how can we improve healthy state. And I kind of put them in four different brackets, which is behaviors, nutrition, supplements, and prescription drugs. And that's my model, right? 80% of the times, if you figure out your behaviors and your nutrition, you live a healthy life. 10% of the times I can do this with some supplements because we just lack those. And the other 10% will give you some drugs to figure out what ailments are caused, right? Essentially, health is, a state of complete well-being and not a reductionist approach, which say Hippocrates gave. Integrative medicine is a healing oriented medicine which takes into account the whole person, right, including all aspects of lifestyle. Because just as no part of the human body functions in a silo or in isolation, I think our approach to medicine should also reflect that interconnectedness. What affects one system impacts the whole, and a true healing really comes from addressing root causes and not just managing your symptoms, right? Now, since our patients seek our guidance and expertise in overseeing their healthcare, I think it's also time for us to realize that the consumer, like you and me, the demand for us has driven the present dynamic of patients, almost paying out of pocket to achieve what is called well-being, right? There's so many wellness gurus out there, and I wanted to give a more scientific evidence-based approach to that, not just backed by science, which all your Instagram reels scream. right? So integrative medicine and conventional medicine are complementary. They're not opposing. So at no point will I say, don't take this medicines or your physician's lying to you. It's just like, let's look at what other things in your life are affecting your condition. So to give that example, a 16-year-old high schooler with persistent abdominal pain came to me. She had bloating, which is that feeling of like a little balloon-like sensation, which means one day you have six-pack abs and the next day you feel like Santa Claus, with bloating, with nausea, with significant school stress, resulting in fast food consumption, right? So she had already seen another GI before, and she was seeing me for symptoms which were persisting and nothing was really helping. So before she even came to me, she'd already told all two of the other GI folks that, hey, my belly's hurting, I get really bloated. And most pediatric GI will generally ask, oh, are you anxious? And she's like, yeah, of course, school makes me anxious. And then we realized that there was some degree of bullying on weight which had happened, in a world which we live in, where being thin is rewarded no matter how you lose that weight. This girl was facing some degree of bullying on weight. They had done an endoscopy, that's the upper endoscopy which we were talking about. They had done some blood work, and they'd also done x-rays and an MRI. Everything was normal. And that is more reactionary, because when the girl complains of belly pain, the mom reacts. The mom tells her physician, oh, nothing's working, nothing's working, nothing's working. And they're, well, she's got pain, she's got bloating, or it must be acid, must be reflux. So she got acid blocking medication, and they told her, hey, you should eat a better diet. Now, going back to what Shaman said, that do we actually get education in nutrition? We do, but the time frame when we interact with a patient is so limited that you're focused on symptoms and you're not really looking at what's going on in their life, right? So you tell me your belly hurts, I'm going to give you a medication for that. So what we did was, in the initial consultation alone, went into further history. We realized that she also had constipation and her belly pain was triggered by certain foods. All right, we said, all right, walk me through your day. Only to realize that she sleeps at 1 a.m., eats Lunchables for school, continues to gain weight, gets nervous on the bus, then ends up vomiting before the first class. And she's like, I've been told to eat healthy and I'm just frustrated. Hence, I only eat one Lunchable a day, and the only thing I do is snack on some chips throughout the day. She was anxious regarding not doing well in class, and she said, well, some of these girls bully me. I am not only am I not pretty, I'm also not doing in class. And before I don't do well in class, I end up throwing. So I miss class. So then I'm behind, and then I don't want to go to school because I'm behind. So we realized that this is essentially what we call as irritable bowel syndrome or functional dyspepsia. Irritable bowel syndrome is essentially, think of, and I want you guys to, because I'm just looking at my slides, but I want all of you to think of the moment where you guys had your first crush, right? If you had to describe that feeling or a sensation to a 5-year-old, you'll probably say, it's like butterflies in my tummy, right? Remember the feeling when you went on your roller coaster for the first time, and the roller coaster drips down. What do you feel? You feel butterflies in your tummy. Remember the time when you got really, really anxious and you still feel butterflies in your tummy. And remember the time when you get super excited, it's still butterflies in your tummy. So nobody walks into my office saying, hey, my crush just passed by and I had this sensation of butterflies in my tummy. I almost wanted to vomit. Because you know what? No shit, Sherlock, you were supposed to feel that way. It's when the stress becomes extremely chronic, your brain stops to tell your gut that, yeah, no shit, Sherlock, you were supposed to feel that way. So the brain just says, you know what? I'm not going to label this feeling anymore. You got this on your own. But the stomach's just reacting the same way. And that's when we start getting frustrated because, like, oh, my stomach hurts or I feel nauseous all the time. Irritable bowel syndrome is that. It's your gut being irritable. It's like when you're irritated, when you're really, really irritable, you haven't slept for so long, nobody can predict whether you'll have a meltdown or you'll just like get really angry. Same with IBS or irritable bowel syndrome. You are so stressed out that there is no way to predict if the stomach will get really backed up and constipated and start to hurt, or you immediately want to run to the bathroom and get so irritated that you want to vomit and throw up. This leads to anxiety, this leads to stress, and this is what we call as the disorder of the gut brain interaction. There is some data on the microbiome contributing to it, but just look at this girl's history, right? Sitting there at your computer desk, think of what all can we do to help her, because the idea is to help her function. The idea is not to name the disease. The idea is not to say, you know what, here, take this magic pill and get better. How can we get you to a functional state? How can I get you to school? How can I get you to not vomit, hopefully? But even if you vomit, don't get stuck in that vicious loop of being anxious, right? So first things for me was, all right, you're sleeping at 1 a.m., you're getting up at 5, 6. Most teenagers think that they can get away with that much sleep. But human brain and human body requires a lot more rest, especially in teenagers. Remember, your body's growing at a pretty fast speed, your hormones are developing. You really need to get some rest in. So about 8 to 10 hours is what you need from the ages of 11 all the way to 25, 26. You need that much of sleep, at least 8 hours. Some kids you can always thrive on less sleep. So you can always survive on less sleep. You will not thrive on less sleep. Secondly, Lunchables. Lunchables actually got banned by 2025, early January. They got banned by California and certain other states as the FDA called them carcinogenic. So think about what a Lunchable is. Lunchable has a deli meat, has some Oreos, and some cheese. That's your standard Lunchable, right? If you get a deli meat or from the actual deli, it'll stick around in your fridge for maybe 5 days. And by the sixth day, it's already gone sour. You can't eat it. And think about a Lunchable. It has an expiry date of 6 months. What are they doing to the same meat that can last 6 months in almost just like the cold-ish section of the grocery store? But a deli meat, which is hang out in your fridge, actually goes bad in 5 days. So they're adding something which makes it stay. When it makes it stay, that means it's kind of a chemical which is going into your gut, which your gut cannot process. When it cannot process, it releases certain fermentable, what is called as oligosaccharides and disaccharides, which are sugars. Now, the bacteria in your gut, the good bacteria which protects your gut, does not feed on that. But the bacteria which actually causes inflammation now feeds on this. When it feeds on this, that multiplies, grows, causes gas production, and that causes bloating. Right? Now, look at the other thing. So she can constantly say, I am still gaining weight without actually eating that much. So now she's in a cycle of, I'm just not going to eat, I'm just not going to eat, which means the body requires certain energy to even metabolize even this quote unquote bad gut bacteria. In order to heal, you need energy. So this becomes counterproductive. A lot of people go on these extreme diets and they end up gaining weight purely because now the human body gets into this mode where it is, I'm going to starve, so whatever you give me, I'm going to try and store. Human body is the most adaptable machine known to man. So it adapts. So a lot of these, just giving that knowledge to the patient, saying, hey, let's look into what you're eating. Let's give you proper food. It's like when you get a plant and it dies, you don't blame the plant, you blame the environment. So if you're not fixing the environment, you're naturally not going to feel so great. If you don't water the plant, it will die. If you don't fertilize it, it'll die. So which means in order for a human body to grow well, you need to nourish it well. So just even randomly giving a patient advice like, oh, come on, why don't you eat healthy, was frustrating. So defining what healthy was, which we already talked about, the processed foods and packaged foods and decreasing sugar. And sugar is another, a whole another talk in its own self. And then anxiousness regarding not doing well in class, which we can address. She was a grade A student, but then she started becoming anxious and started to vomit. She started to miss class, and that would just put her in this rut of getting stuck, saying, what's the point of doing this? I'm not going to do well in class anyway. And therefore, we tried to start addressing it, saying, let's break down your mammoth anxiety of this negative noise down and say, how can we focus on the moment of that assignment instead of saying, oh my God, I'm going to fail my finals. Let's just focus on one assignment at a time. And that breaks it down. Anxiety typically does not last when you break it down in really small, objective, meetable goals. And then the last thing I told her about was being pretty. Pretty is such a subjective thing. And then at least I told this girl, I'm like, have you ever looked at yourself? And she said, of course, yeah. So I'm like, actually, you've never looked at yourself, right? Because as human body, as human beings, we don't look at ourselves. We always just look at our reflection, which means it's very different than what the other people look at you as, and very different than what you perceive your reflection to be, right? If as many of you would have walked into a gym, really nobody cares how you're looking. It's our mind who perceives that, oh my God, somebody will be looking at, looking at me, somebody will be looking at my hair, somebody will be looking at this, is my shirt tucked in or not? Most people 90% of the times really don't care. So if in your reflection you can look and say, I'm perfectly fine and I can glow and I can be healthy and I can be pretty, that changes the perception of other people. So it's about reframing, it's about learning the psychology. And obviously it's not as easy as I'm making it sound. It requires a lot of work, it requires a lot of time, but it also requires a lot of empathetic listening. And so for her, we said, you know what, let's address some of these things. Let's talk about behaviors. Let's start sleeping on time. But one good technique to sort of lower that anxiety is called as diaphragmatic breathing, which is essentially you activate your diaphragm and you breathe into it, which is and once I turn off the slides, I'll teach you how we do diaphragmatic breathing. Basically, it activates your vagus nerve, which then stimulates what is called as the calming nervous system in your body, and you feel naturally calm by this specific breathing technique. It's an old yogic practice, but we've kind of tuned it to suit the modern day world. The nutrition. We talked about educating and coming up with some easy anti-inflammatory diets. We talked about being plant forward, less processed. Supplements. She was constipated. There's an Eastern herb called triphala, which is called the elixir of the gut in Ayurveda. We started her on that. Magnesium really helps with sleep, and then peppermint is a natural antispasmodic and a natural anti-debloat medicine. There's an herb called iberogast, which is a combination of lemon balm, chamomile, peppermint, caraway, lavender, and iberis, which really helps soothe the tummy without any kind of side effects of belly pain medications. And then prescription drug. There is a prescription drug which the days your tummy really is not cooperating, there's a medicine called as hyoscyamin, which you can put under your tongue and works on your intestinal muscles, and it really prevents that cramping, that irritable feeling of that gut when it is cramping. Lo and behold, we had like three more sessions, each of them an hour long, and each time we reinforced this, each time we talked a little bit better, and then she actually got better. So this picture is actually from a magazine interview which she gave regarding how she felt better after she understood her body. She did not lose a whole lot of weight, but she actually stayed the same as exactly what she looks in this infographic, and she became a lot happier. She ended up going to UPenn for undergrad and pursuing pre-med. So it was great when she actually was able to overcome that, and she hasn't seen me back in about a year and a half now. So diaphragmatic breathing, that's exactly what I wanted to talk about. It's essentially what you do is when you inhale really deeply, if you bypass the lungs. So think about if you've played charades, right? All right, I'm going to exit this and I'm going to tell you what diaphragmatic breathing is. Is that okay? All right, can you see me? So have you guys played charades? Yes, no? Yes, okay, I got some nods. So if I told anybody to enact panic, how would you enact? All right, so most people will go, right? That's panic. So that's shallow breathing. What deep breathing does is the complete opposite, right? So if you deep breathe, you go, and if any one of you has actually Apple Watches, if you try and deep breathe for 10 seconds, hold your breath for 10 seconds and breathe out using your mouth slowly for 10 seconds, you do it 5 times and you'll see your heart rate come down, right? This is a cue to your body that I can override your panic, right? And there's the same way, there's an ancient yogic technique called the 4-7-8, which means you breathe in for 4 seconds into your lungs. And so into your lungs, meaning that you put your hand on your tummy and you want to just breathe into your tummy, which is your diaphragm is right here. So it actually gets pushed down. When the diaphragm gets pushed down, it actually activates what is called as a vagus nerve. And that vagus nerve tells your brain, hey, chill out, right? So you go, so my hand doesn't move on the chest. So you're basically bypassing what you think you're bypassing the lungs, which you're not. But it essentially is just flattening your diaphragm and then hold it for about 7 seconds and you breathe out for really slow through your mouth through 8 seconds. And if you do this 3 times, that's in 1 minute, that is enough to generate a decrease in heart rate of about 10 to 20 beats per minute. And that sends a signal to your brain that I'm okay, life's okay, I am calm. It also gives you the moment to step away mentally from that situation, which is like a hamster on a wheel, right? It just makes that hamster step out of the wheel, and that wheel is spinning. It doesn't matter. Like the world is not going to collapse. Sometimes just realizing you're very insignificant in this world actually helps you realize that your problem is not so big. So just about getting off that anxiety mode can prevent a lot of bad decisions you make in that day. So a lot of this is just training that. It has an added benefit that if you're somebody who suffers from reflux, there's an actual valve here in the esophagus, this is like strength training. It's going to the gym for the internal valve, and it strengthens so things don't come right back up. So that's what I want to teach you guys about diaphragmatic breathing. But this is what I mostly talk about with every patient.
That was incredible. Probably one of the best case study presentations we've had. So thank you so much for doing that. Thank you everyone for joining. We do have an OB-GYN resident tomorrow. If you want to register, I put the link in the chat. Dr. Setya, thank you so much for doing this, spending almost an hour and a half of your time on a Tuesday evening when technically this is when you should be resting and enjoying your time. I thank you so much for taking the time to talk to us.
Thank you, guys. Thank you for being so patient and actually showing up for this. I really, really appreciate the opportunity to talk to you guys, and wishing you all the very best. And I hope I made some sense and convinced at least 8 of you to come over to the Peds GI world.